Okay, I think we're going to sort of get started. I am not the beautiful Dr. Jonathan Galley, but I will also be the moderator today. My name is Keho Wong. I am at University of Utah Neurology, working in the neuroimmunology and autoimmune neurology session. So today we have four wonderful panelists. I will let them introduce themselves.
Is this working? Oh, this. I'm Tracy Schaffer. I'm actually one of the nurses that works at the University of Utah in autoimmune neurology, neuroimmunology.
My name is Regina. A lot of people call me Reggie. So I'm one of the nurses at Primary Children's working on the ped side of neuroimmunology.
My name is Erica Marini. I am the clinical pharmacist at the University of Utah Neurology Clinic.
I'm Taylor Berhow, and I'm a licensed clinical social worker who works in our integrated behavioral health program in the neurology clinic.
Well, great. So I will start the questions from Taylor's side right now. So could you kind of tell us what is your day-to-day work or day-to-day challenges that you see a lot in our patient population?
So in the University of Utah outpatient neurology clinics, there are 3 social workers, and we actually all function in a sort of mental health related role, and so we are in the clinics day to day and also see patients for therapy, mental health therapy, when indicated either by themselves or by the providers. I would say, the biggest challenges are, mental health related, and you all probably know them better than most, but managing the stressors of dealing with a neurological condition, and navigating our own mental health challenges that people face in and out day to day. I would say with this patient population specifically, it's really isolating, and can feel really lonely, and that can add a lot of extra just like stress and pressure when you're trying to just live and survive. And yeah, my day-to-day is a mix of seeing people for therapy and being available when you go to your doctor's appointments. The providers will pull us into rooms if necessary or needed, and so it's kind of a mix of all of those things.
Did you want us all to answer that? Okay. Cool. So as the clinic pharmacist, I obviously deal primarily with medications. So both with medication access, which in this group is a particular concern because we're often using medications that are quote unquote off label, and so they weren't what initially got the medication approved by the FDA. And a lot of insurance companies, especially like Medicare, will only cover things or will only want to cover things if you're using it for the indications that it was studied for. And so it is definitely a challenge in rare disorders to make sure that we get patients on the therapy that is best studied and has the best evidence and the best outcomes. And so in this population, I do a lot of that. And then anything that arises, so side effects that come up, weird schedules, you want to go on vacation and we need to work around it, like all of those things, just kind of random, and anything medication related is really fair game in my day-to-day.
Day-to-day wise, I feel like we are doing a little bit of everything. With the peds population, we don't, I don't want to say we don't necessarily have a lot of resources, but as far as medications that are approved and, our specific group of patients is not very large. So we get to wear a lot of hats, and that's great because we can really help kind of personalize care. As far as kind of the challenge with that, I think it's probably access to medications and resources for such, rare disorders that are even more rare in pediatric populations. So that's always hard, but we've got a good group fighting for it.
I'm a lot like Reggie, where I wear many hats. I actually work with 7 different providers in our clinic, anywhere from autoimmune to the neuroimmunology type neurological conditions. So anybody who's familiar with how the University of Utah is set up, our system, patient messaging system is through MyChart. I'm the one who actually answers every single message that comes through for my 7 providers. So I can answer anywhere from 500 to 600 messages a month. And I do all refills. So any refill that comes through, I'm the one who refills there. So again, about 200 to 300 refills a month that I go through. I'm also responsible for setting up home health, physical therapy. I do a lot of appeals on medications that maybe, if it's not like an IV medication that Erica might be doing, I would do appeals on other oral medications. I go in and meet with patients. Oftentimes when they're new to their diagnosis, I'll go in and meet with them, just sit down and chat and kind of give them a nursing side. I always say I'm a little bit softer sometimes than our doctors, because they go in and just say, here's your diagnosis, this is what we're planning on doing, and then kind of go from there. So I do a lot of follow-up, just making sure that patients are taken care of, and just kind of my day-to-day. I know Reggie and I were talking, we're not always in the clinic, even though we work 40 hours a week. We do kind of split our time. Like I split a couple days a week at home where I can be on the phone with the insurance companies, which I do a lot of arguing with them. So even to the point of trying to get people wheelchairs, which unfortunately is not something easy that we are faced with. We're fighting insurance companies, writing appeals for them as well. So that's my day-to-day.
So one of the questions I would have is, what is an effective, I mean, Tracy just mentioned you get 500-700 MyCharts, and maybe even more if we add in phone calls as well too. And you know, you're one person, and then Erica, I know you're one person pharmacist who service the entire our neurology outpatient clinic as well too, who has 40 neurologists. Same thing for you, Taylor. What is an effective way to communicate with you guys that within 1 to 2 messages or a 5-minute phone call, we can say, okay, we got what we needed. Give us some advice, give us some suggestions, and maybe we'll start with Tracy first this time.
Keho actually asked me to write up a little slideshow type thing on effective communication. So as I mentioned before, at the University of Utah, we do use MyChart, and I know as Intermountain switches over, they're going to be on Epic, our same system, so they'll be using the same type of messaging. I'd say the big thing is making sure you're letting us know what you need, that first message that comes through. Because when we're getting a message that says, I need a refill, but there's nothing to say what refill you need, and you have, 5, 6, 20 different medications, I'm gonna have to now send you a message that says, which medication do you need a refill on? Or, something as simple as, I need you to call me. Well, tell me what I'm calling you about, because I want to be able to get into your medical record and actually read through it to know who is this patient, what is it, their diagnosis, what is, possibly their question that I'm going to be calling them about. And also expectations. I just said, like in my role as a nurse, I'm answering 500-600 messages a month, 200, 300 refills, couple hundred phone calls. So when I get that message through, we can take up to 48 to 72 hours for a turnaround time to those messages. But if your concern is urgent, don't wait for me to respond to you. If it's something that you need to go to the ER for, or you need to, talk to your provider or something, call us. I always tell patients, like, I'm the gatekeeper to my providers. I know where they're at. I can hunt them down if it's something emergent, but they're allowing us as nurses, we have the education behind us. No, we don't know every single thing about your disease, but we can direct you. So expect a response, but it may not be as soon as you send us a message. I say this isn't texting. I'm pretty good at texting, but sometimes when I'm doing multiple messages and I'm going in to see patients or I have a phone call or something, I am not able to get to you as quickly as I would like to.
Very well said. I think as far as kind of just echoing that sentiment, like help us help you. You are your biggest advocate, but we are all on the same team trying to achieve what you need. So be as specific as possible. If you have times of the day that don't work to call, and I'm calling you every day at 9 o'clock, we're not gonna put together a really good, system of communication. So figure out what works. When you really need us, if you haven't heard back from us, call us again or message in and say, there's, something's not right, or I need more help.
Yeah, I probably don't have very much to add, apart from like if you are a patient at the U and you want the eye of a clinical pharmacist on your question, whatever it may be, I'm not going to be someone that you can like pull down in your MyChart to message directly. So if you do, it would definitely help like whoever your nurse is, Tracy or whoever, if you put in there, hey, can you send this to the pharmacist to answer? Then like she doesn't really even need to read the rest of the message. She can move on to the other 499 messages she has, and then she can forward it on to me, and then I can get you the answer you're looking for.
And I'm clapping. That's going to Erica.
And same with a phone call, the people who answer the phones know who I am too and can route phone calls to me. I have a secure voicemail if someone needs to leave me a message. And so while I am not, sort of by design, the most easily accessible person, you can't Google my number and you can't, find me in MyChart, I definitely am available. But indicating that you would like my eyes on it or the clinical pharmacist's eyes on it will help it get to the right place and get you the answer quicker.
Ditto. No, I mean, same idea. When you have a mental health issue or you're concerned about mental health medications or concerned about, mental health symptoms, that's again my role, and similarly not easily like directly accessible, although I do have a direct line that I can give patients when needed. Same thing, you can just indicate in a MyChart message that you would like this to be passed on to one of the LCSWs, and the messages can be routed to us.
Great. I actually see 4 patient advocacy leader here. We have Neo from SPSRF. We have Meg from AEA. We have Michael from the TSF, and then we have Justine as well too. So tell us what would be helpful to put on their website to communicate with the patients, because they serve a huge population. It may not just be University of Utah, it may be anywhere else, right? So what would be helpful to put it on their website and say, like, this is how I communicate with my pharmacist, this is how I should get a hold of a social worker, this is how I should get a hold of my nurses, how my nurses could, get a hold of my clinician. Like, how should they do that the patient doesn't feel like they're overburdening the clinician? They're not. Sorry, go ahead.
No, can I add an extension?
Please do.
I think so. We have a lot of instances where our community members will reach out to us and they're frustrated because they're seeing a new doctor, right? And they come in with a notebook this big, they kind of put it on there, and they're like, you didn't even look at it. And I'm like, well, it's not really reasonable to expect. So what is the fine line, right? You want to give as much information as you need, and it's important, but you can't expect somebody to sit and read a novel either. So how should we guide our community members on things like that?
I'm not a doctor. I've worked in this space now for, a decade or so. I would say, and I work a lot with patients who are frustrated with their medical experience and who have experienced, medical related small t trauma, sometimes large t trauma, or have had frustrating interactions with their medical team. I would say, we don't live, unfortunately, in a healthcare system anymore where you get that like sort of local doctor who's going to spend hours and hours with you, right? And so one thing to note is just like that's not an expectation to hold. I think that you'll always be disappointed if that's your expectation. For as much as we would all like that, that's just not how it works anymore. I would say managing expectations from like a mental health perspective is is really crucial to success and to like feeling like you're having a successful relationship with your medical team. I think, that like that fine line that you speak to, right? It's really hard to not, it's challenging, right? Like you want to go in and share your whole entire experience with your provider, and you will feel disappointed if they're like, I'm not going to look at this whole thing, right? Maybe they want to, but like, right, they have their own limitations on how much time they can spend with patients and, how much energy they can give to patients, right? We have thousands and thousands of patients in our neurology clinics, and obviously a limited number of providers, limited number of nurses, one pharmacist, right? So I think that's the biggest thing is like, right, it's challenging, but managing expectations is really important. I would say the other piece is that medicine, I think for better myself, is I think shifting into a space where doctors recognize that they're not the experts in everything. That's why we have like a clinical pharmacist. That's why like my team works in the clinics, because they're not the experts on mental health. They're not the experts on medications. And so if you have specific questions about something that isn't directly, right, like that is maybe a little bit more specialized, right? Even like physical therapy or occupational therapy. I think more and more providers and, medical providers are recognizing that they're not the experts in everything, and they want patients to have access to people who are. So just because we don't have MDs behind our name doesn't mean that we don't know, more than them in some cases, right? I mean, our providers are referring patients all the time to me for issues that they're like, I have no idea what to do with this, right? And so that's something to note too, that, right, it feels really good to have like a doctor listen to you, but, right, doctors don't necessarily know about, using behavioral therapies to treat like depression and anxiety symptoms, right, which come up a lot in this setting. So that's kind of what I would say about that.
Yeah, this is probably not my arena to answer. I think that I think it's important to, if you're having a first visit with a provider, know the structure of that clinic and the resources that clinic has for you. So, or ask about them. Like, when I send a question in, who's gonna answer that question, and about how long does it take to get a response? If I have a question about medications, should I call my pharmacy, or do you have a pharmacist in clinic? Because it's not, I'm here, I think Intermountain has one, so it's becoming more common, although it's not 100% of the time that you would have a pharmacist directly available to resource. So I think that can definitely help. And also making sure that you have maybe 2, maybe 3 key things that you want to talk about with your provider that day, to make sure that you're having a useful, really comprehensive conversation about a few things. You might not be able to get through your all of your records, which the provider hopefully has access to, because we require them when a referral is sent in. So hopefully they do have access to that even before the appointment, and have looked, however comprehensively they can prior to your appointment. But, being able to have a comprehensive discussion about a few things can often be more rewarding and a better appointment than trying to get through everything at once.
It sounds a little simple, but I think just making a list, like you had said, when you wait so long to get an appointment and you have no idea what's going to happen or who this provider is you're going to see and meet with, and who else from their care team, I think it's really important to have the questions that are really important to you to have answered and bring that to the table. I'm not sure what your experience on this is, Tracy, but I feel like more often than not, we'll have a new patient come in. Obviously it's a huge diagnosis, and families aren't thinking necessarily about, what to ask in the moment, or, the new doctor comes in and, completely just overwhelmed. So having a list, I think asking that provider and using their valuable time then, and then if other questions do come up, you can of course pass them on, but I think that's, the best time to kind of go through that and spend that time. And then, knowing your resources. So how that clinic is set up, the doctor isn't going to know everything, like you said, but I think there's so much more that meets the eye, in the sense that it's kind of like that iceberg. You've got your doctor up here, but then you've got your nursing team, your pharmacy, and everybody else that you don't even know is contributing to that patient's care.
I also agree with all three of them because I feel the same way. One of the things that I do like to mention, though, especially to patients that maybe are seeing another provider outside the University of Utah system, we try really hard to get all those medical records over prior to the visit. But one of the things that can be frustrating for patients, especially, let's say we've seen that patient, we've ordered imaging, we've ordered labs, something like that, and then they go to a different facility outside the U, say like they go to Intermountain. I don't know, and I'm usually the one who's trying to chase down those medical records. I don't know that that patient has gone to, Intermountain Medical to have their MRIs. I don't know that that patient's gone to, St. Mark's maybe to have their labs drawn. Without you sending me a message and saying, oh, hey, by the way, I just had these labs drawn, or I just had this imaging, that sits out there. I mean, it literally sits out there in their system until I'm able to call and pull that stuff over. So when we talk about like a team, it truly is a team effort. All of us are working together. I mean, we all have some part in your care, and it's, not just one person over another. We are all specializing in your care. Even to the point, I mean, I hear like the doctors go in or the providers go in and talk to Erica. Hey, Erica, what about this? Or Taylor or whatever. And as a nursing team, they're coming in saying to us, how do I get this patient in a wheelchair? How do I get them set up on home health? What do I need to do with this? They have all this knowledge, but we have a lot of knowledge too that we all are working on to get those patients what they need.
Please.
Become a discussion instead of.
Yes.
I feel like we need to sit down and have a working group and say, for your clinic, because if I just got diagnosed with something I've never heard of, I am not going to think to come into you and say, so tell me, how exactly should I communicate with you? I've lost my mind. But if we could come up with, again, for your clinic, what do you need people to know? And we could have that on our website is print this off, take it with you. Probably not going to be your first visit, but then that takes care of your clinic, because there's not clinics set up like this, right? There's so many that aren't, so it's like we then need to reach out to 10 other places and have all these different, it's hard. It's amazing what you're doing. So in my frustration, I want to say thank you, because what a model you have here.
Thank you for that. Something that is coming to mind for me, I clinically specialize in anxiety disorders. So I work a lot with different anxiety disorders, health anxiety, medical anxiety, obsessive compulsive disorder, things like that. No. So I wanted to break some news to you. One of the nonprofits that I work with really regularly is the International OCD Foundation. You should check it out. I'm just kidding. They, on their website, have this really great sort of web page that's just like how to look, like basically how to look for and know that your the therapist that you're working with actually knows what they're talking about with OCD, right? And then it has these questions that you can ask them, right? It says like, ask them like what their specific training is, ask them what percentage of their caseload is individuals who have OCD, like ask them, right? Like all these different questions. And I'm wondering if something like that, not like how do you know whether your doctor, right? But like it could be beneficial for any clinic to just like ask them if they have like a mental health specialist or a social worker, ask them who manages all of the like DME type, wheelchair and medical equipment type questions, who manages and can, help with medications. Like, is there anyone who I can talk to about like my mental health or, right? Like those are the types of questions that anyone could take to an appointment at any clinic and maybe have like a good, get a better sense of how that clinic operates.
And if we created it, it's something we could have, but it's also something clinics could have. Because somebody's going to walk in and you could at least say, ask these questions. You need to find these things out.
Yeah. I mean, from my perspective, I encourage providers when patients are newly diagnosed to reach out and place a referral to someone on my team. But if the patient asked for that, right, like that would even be better. Like, hey, do you have I'm newly diagnosed here. This is a really big deal. Do you have anyone I could talk to about this? Maybe not long term, but even just like for one visit or something.
Yeah, so these sessions are being recorded for other people to watch after the fact, so we're trying to get the questions on the mics as well, just FYI. There's kind of an elephant in the room for all these conditions in my experience, which at least for it affects us in NMOSD and MOGAD, and I'll give you two scenarios, and I'd love to hear your thoughts on these two scenarios. So the first is, in NMOSD, the approved therapies, they're all extremely expensive. Once they became available, insurance companies started to require people to step through off-label therapies like rituximab, sometimes even mycophenolate or azathioprine as well. That's one scenario where the drug's approved, and if you're aquaporin 4 positive, you can have access, but then it becomes a challenge, and it's by far the biggest cost. And for the folks in the room that don't know this, these are drugs that cost $200,000, $300,000 a year for the rest of your life. The most expensive one is $750,000 a year, every year for the rest of your life, which is why the insurance companies really hesitate to allow access. So, but nonetheless, they're approved, so, you know, they're available, and maybe a certain patient newly diagnosed should be on those right away. The doctor has decided they shouldn't be on these other therapies for whatever reason. So how do you handle that, and how hard is it to get those patients on those therapies once you've decided that's the best course of action? The other, which it affects a lot of the other conditions we talked about today, no approved therapy, but some of these therapies can be used off-label, and they're also still expensive. Even rituximab is still costly, and many insurers will deny that because they'll say there's no data, and then you're in a, I don't know, pharmacy and therapy committee argument, or you're going to appeals, or you're looking for compassionate care donations of drug, or as Dr. Lavasio said earlier today, you know, the hospital will sometimes find a way to cover that patient and, you know, take it as a tax write-off, you know, basically charitable care on the part of the provider. But both of those are terrible situations, and many patients give up after a while. They lose energy, or they don't know how to navigate the denials, how many times they can appeal, who else they can you know, leverage to help their case. So if you could just talk about both those scenarios, both the on-label but still expensive, and then you're in a battle there, and then the off-label.
Yeah, battle's definitely the right word for that. Let me collect my thoughts in a politically correct way for how I feel about insurance companies.
It's too early for that talk, by the way.
Yeah, no, but it's such an important question, especially in this population, and it is probably the number one frustration, because treatment is often the most important thing that we can do for rare autoimmune conditions, neuroimmune conditions, and we in my 11 years in clinic have never had to have a patient not go on therapy. You know, luckily, we've always found a way. It's kind of it's an escalating approach. So to your first scenario, you know, NMOSD, you know, existed prior, and there are now FDA-approved therapies just in, you know, the past few years. So prior to that, you know, basically you used, you know, lesser effective therapies, or you used rituximab, because there was a big study that showed rituximab is better. And so it used to be rituximab was difficult to get approved because it was a brand name medication. Rituximab is now not difficult to get. We are big fans of what are called biosimilars, which, so in the realm of medications, I think most people are familiar with the term of a generic medication. Most, you know, I think 90% of medications dispensed in the US are actually generic medications. We take them, you know, instead of taking brand name Advil, you're taking, you know, Costco brand ibuprofen. That is a generic of Advil. So we're all very familiar with, and we're all very comfortable with using generic medications. Biosimilars are needed. We needed to come up with a solution for these complex molecules like rituximab, which are not in an oral form. An oral medication is considered a small molecule medication. If you need to give something by an IV or by an injection, it's generally a large molecule medication. It's complicated to produce and complicated to engineer, and so it needs more data before you can before anyone would feel comfortable giving it a generic. And so you don't have generics for things like rituximab. You have what's called a biosimilar. And so where a generic just needs to prove that you are, bioequivalent, that you are chemically the same as the originator product, a biosimilar to something like rituximab actually has to prove, efficacy, prove that it works the same way in the body as the originator product does. And so there are now 3 biosimilars to rituximab, and we feel comfortable using them because they do have that extra data. Biosimilars do offer significant cost savings because they bring pressure to the market. That's what generics do to bring down prices. That's what biosimilars do as well, because they offer alternatives. So there's not just one person that can, slap a price on something because there's no competition. There's now competition, and so it drives prices down. So by using biosimilars, insurance companies now hardly ever give us trouble if we're willing to use a biosimilar for rituximab. That being said, a lot of people will want to use a new brand name option for NMOSD because the rub is that you can use rituximab, but it's not approved for NMOSD, and so you can't use resources like a copay card, which would mean you'd pay, the patient out of pocket if you're commercially insured, so not having Medicare or Medicaid or a federal plan. You can use a copay card for something like Uplizna, which is FDA approved for NMOSD. And, even though Uplizna costs, I think, maybe $120,000 a year or something like that, don't quote me on that. You out of pocket.
Where's our Amgen people?
Yeah. You out of pocket would pay nothing for the medication, and they cover the administration too. You would pay maybe $10, maybe nothing, depending on the copay program structure. Now, rituximab is much cheaper, but you can't use a copay program. And so, providers are very, they're wise, they're smart. They went to medical school, they're smart. They're like, hey, well, I want my patient to use this medication. It was studied specifically in NMOSD in a really large population. And also a patient can use a copay card. I want them to do this. And so, of course, those are absolutely valid reasons. And so we put it through insurance. Sometimes insurances are easy to work with. They recognize the utility of something being FDA approved. They recognize the rigor that takes to actually get FDA approval, and they'll cover it. But to Michael's point, a lot of insurances still will require step therapy. We don't see with the really inferior medications like mycophenolate as much anymore, but we will see a lot of insurances still say you need to step through rituximab to get through to some, an FDA approved medication. And so unfortunately at that point, we don't have necessarily a reason to not use rituximab, and so that is a discussion, and it's often a discussion of of timing. Like, do you want to get on medication as soon as possible? Then we can do what insurance wants. We can give you rituximab. It does work, and we can do that, and we can get you started. We can get you infused probably next week. If you're willing to go through, the extra step, the first step generally is a peer-to-peer. We have very aggressive doctors in our clinic. They know the deal, and a peer-to-peer is often successful. And that's essentially like a doc-to-doc discussion. Often the insurance, it's to your benefit almost because the insurance doctor is often not specially trained in these disease states. And if your doctor, which we are, is able to adequately and aggressively, while still being obviously polite and respectful, make sure that it is known how much more they know about the disease state than this person does, then that's generally been successful. Beyond that, we write appeal letters, which are also aggressive and very well researched and cited, which is important. And so, we do what we have to do to get our patients what they need. I'm not going to tell you that we've never had to be like, hey, we we need to do rituximab because we need you to get treated. I'm not going to say that we've never done that because we absolutely have. But we take things as far as you want to take things, essentially, in that battle. The other question you had is about completely unapproved disease states that don't have anything approved. And that is essentially the same thing, except we might even start, for many of these disease states, unless you're something that's, everyone has a rare disease if you're coming here today, but if it's so rare that we've never even seen it before, then you're the icing on the cake. But for most disease states that don't have an FDA-approved medication, so something like sarcoidosis, there's an established therapy, it's called infliximab, but it doesn't have an FDA-approved indication, and if something is that rare, it's never going to have an FDA-approved indication because it costs billions of dollars to get something to have an FDA-approved label on it. And for these medications that are all, off patent, they're not making very much money anymore. It just doesn't make sense, and you can't argue with the manufacturer about that because it does make sense for them to go back all the way to square one, which is what they'd have to do to get it approved for a new indication for a rare disease that doesn't affect very many people. And so often though, it is, I'm not going to say easier, but it's sometimes more straightforward to get something approved off-label because there's going to be no step therapy because they don't know what this is. So you will often start kind of on the attack. You will start on the offense if you're trying to get something off-label. You're not just going to submit, there's no special form for that. You submit a generic form, but you're going to submit, I'll submit at least 2 articles that show that medication has been worthwhile and has been found to be useful in that indication. And so you just start off on the offense with the insurance, and that's been successful in a lot of times, and then you just follow the same road there. And then, if we need to, we often will use like patient assistance programs, which are free drug programs from the manufacturer. A lot of programs won't allow you to use a copay card if you're using something for an off-label indication, but you can usually use, I would say sometimes, use the free drug program, even if you're using something off-label. So for the brand of Rituxan, which still exists, that's the case. Unfortunately for IVIG, you cannot, and there are no biosimilars to that available, but so there's different tactics. We work really hard on it. It's a big part of my job. But yeah, it is a definitely concern, and it's always a really good day when you're like, oh, it just got approved. I was like, I was bracing myself for a denial, and it just got approved, and it was wonderful.
Are there any resources available?
Sorry, I'm going to induce you.
That's all right. All right. Are there any resources available that we could use or that we could point our patients to help guide an understanding as to, like, this is the way insurance is thinking about this? You talked about the idea of, like, we may have to be aggressive when we go in and submit stuff ahead of time. Are there resources out there, or is it really just like it's a one-off scenario, we just got to figure it out as we go?
I think that is a main frustration in the current healthcare system of America is that all of these private companies can basically operate however they want to. There's no, from one insurance company to another, even from one Blue Cross, you think Blue Cross Blue Shields will be all similar. They are not. Every single plan, even under the same main company umbrella, can just adopt whatever guidelines they want. You do see similarities when you're dealing with the drugs, over and over and a lot of the time. But unfortunately, I would hesitate to provide a resource that would not be universally helpful, and I don't think that there is one.
Tracy, same question for you. As you're like trying to get through non-pharmacy stuff, but like wheelchairs, same scenario for you as well.
So I think of when I think of wheelchairs, because that's one of those big, costly DME pieces of equipment. But what I did is, like, I've worked with wheelchair companies who have said, like, how can I get this approved? What is it that I need in the chart, exactly. And so when my providers go in and I'll say, oh, hey, this patient's coming in today and they are going to request, say, a motorized wheelchair, I have a phrase that you can just insert into that chart that says, basically, like, this is what we're needing. Now, have they still been denied? Of course, they will get denied too. But I've found as long as we kind of jump through those insurance hoops, and we're putting the wording in exactly like they want to see, then I have a better success rate of getting something approved. As far as like wheelchairs and stuff, Medicare will only pay for a brand new motorized wheelchair once every 5 years. So if a patient calls me and says, I need a wheelchair, I want, this type XYZ, I'll say to them during that conversation, okay, we can only get this approved in 5 years, every 5 years. Is this something that you think maybe in 2 years you're maybe going to have a different type? Because if so, we're going for that type. We're going to leave these other types aside. And so there's a lot of kind of, I think, as Erica mentioned, you kind of learn, but there's so many different insurance companies out there that you're learning every time you go. I mean, every single patient's going to be a different story.
Sorry, it's going to come back a little bit to the same topic, but because this, for example, so Samira herself, she's publicly disclosed this. She cycled through 9 different therapies. She failed on rituximab 3 times. She's seronegative, so she still doesn't qualify for any of the approved therapies. But the one that worked for her was the first one approved. She even got on it before it was approved, Soliris. That's a whole separate situation because she's seronegative. There's still no FDA-approved therapies for seronegatives. But many other conditions, for example, MOGAD right now, nothing approved. Many patients have to cycle through off-label therapies. And what we hear from these communities, and I think it's true also for AE, the doctor decides we should try rituximab or IVIG or plasma exchange monthly. These are all biosimilars. They're cheaper than rituximab, but they're still not that cheap, right? The more biosimilars we get, the cheaper it becomes. However, they're still costly, and many of these patients are denied by their insurance companies these off-label therapies. So is that when you all? I mean, is there another route like pharmacy and therapy committee escalation, and then you do revert to hospital charitable care, or have you seen this challenge with these rarer conditions, nothing approved, and the insurance company will say, well, we won't even approve off-label rituximab because there's no data to support it in this indication?
Yes, we have. We have run into that. Luckily, you can still get brand Rituxan through the Patient Assistance Foundation if your insurance has what we refer to as a double denial. So they've denied the initial request and then they've denied the appeal. The Rituxan Foundation will still give you free drug. And so that is what we do in that case. It is, it delays things. We aren't happy about it. But we do it. We often, and we also have to do it if patient had, an insurance that approved it. That doesn't mean your next insurance, if you switch jobs or that doesn't mean your next insurance will approve it. And that also becomes a big issue. Have we ever had a patient that just couldn't go on therapy? I honestly cannot think of one. And I'm not taking credit for that. I think it's a lot of, we are just, you have to be relentless, honestly. We had, and it's not just from our side as well. Like often we will get into these battles and we do send messages to patients like, now is the time that you need to call and ask who your advocate is at the insurance company. You need to be, we are being a squeaky wheel and like you need to do so as well. Because often that can be kind of the hair that broke the camel's back. I don't even know if I'm using that phrase. Straw, yes. Hair works. I know, I was like, what's on a camel's back? That's not straw. I even thought about straw. It's like, there's no straw. Anyways, you guys get it. that can be something that's successful. We had one patient who was, she's got all sorts of rare stuff. She goes to like the NIH, and she, through her church, knew like the vice president of the insurance company, and like she, so, going through your contacts, I don't think that scenario is ever going to come up again where someone like that. But you can, and often for people with high utilization of medical resources, insurance companies will have nurse advocates to help you. And there are times when they have been helpful, and they have fought for their patients. And so making sure that you contact your insurance as well can be helpful. That's just something from the other side. But we go as far as we need to get patients on med. I honestly am still trying to rack my brain, and I can't think of anyone who has gone without therapy. Eventually, if you threaten going to the Attorney General, people make moves. So.
Well, I think our session is over for today, so let's give a round of applause to our panelists today.